It's easy to think about our health in separate boxes, isn't it? You know, genes here, diet there, exercise.
Right, compartmentalized.
Exactly. But what if we zoom out? Look at the bigger picture. How much does our actual surroundings impact us, everything we're exposed to?
That's precisely where we're headed today. We're doing a real deep dive into this huge interconnected world of environmental and nutritional diseases.
Okay.
These aren't just things that pop up from inside us. They often stem from, our constant interaction with the world, the air, the workplace, the stuff we consume, the food we eat.
It feels like shifting that perspective could really unlock a new level of understanding about health.
It really can. It helps you see the connections.
And this isn't just a minor issue, is it? The scale seems enormous when you look at global health.
Oh, absolutely. Just think about this one stat. The International Labor Organization estimates something like 2.3 million deaths every single year just from work-related injuries and illnesses.
Wow. 2.3 million.
Yeah, that alone gives you a sense of the massive impact our environment has globally. It's a major force.
Okay, so let's really unpack this today. Our goal is to get into the weeds, understand the connections between, say, climate change, toxic agents, chemical, physical, and of course, nutrition.
Exactly.
We've got some comprehensive source material here, and the aim is really to master this information, to get that kind of professional level grasp on it.
Precisely. We want to connect those dots for you, show the mechanisms behind it all. Understanding these links gives you a much, much deeper appreciation for how intertwined it all is: environment, nutrition, and health.
Right. So let's jump into a really big one first. Climate change. We hear about it constantly, usually with ice caps or weather events, but our source frames it as a key cause of environmental disease. How does that connection work?
Well, the material is pretty clear on this. It identifies climate change as probably the preeminent global driver of environmental disease this century. And the evidence is compelling. We've seen really significant global warming trends since the early 1900s, and it's picked up speed recently. Take the period 2014 to 2018, that was the warmest 5-year stretch since we started keeping detailed records back in 1880.
Wow.
And just looking at 2018, the average global land temperature was 1.1 degrees Celsius higher than the 20th century average. Ocean temps were up to about 0.66 degrees Celsius. These aren't small changes.
No, that's a definite shift. And the science is pretty settled on the cause, right? Human activity.
The consensus is overwhelming, yes. It's primarily driven by us, by the increasing greenhouse gases in the atmosphere: CO2, ozone, methane.
Right.
These gases trap heat naturally, which is good, keeps the planet habitable. But burning fossil fuels, deforestation,
Yeah.
we've dramatically increased their concentration. More gas means more trapped heat.
The greenhouse effect amplified.
Exactly.
And the CO2 numbers themselves are pretty stark, aren't they?
They really are. Back in 2019, atmospheric CO2 hit 410 parts per million. To put that in context, ice cores tell us that's higher than it's been in roughly 650,000 years.
650,000 years. That's staggering.
It is. And the projections are even more concerning. If things continue, we might see levels between 500 and 1,200 ppm by the end of this century.
Which is?
Levels the Earth hasn't seen for, tens of millions of years. Plus, deforestation means less CO2 gets absorbed. It's a double whammy.
Okay, so more CO2, more heat, higher global temperatures. What does our source say are the direct health consequences of this warming?
Well, the link is multifaceted, and it's significant. Climate models are projecting a global temperature rise of maybe 2 to 5 degrees Celsius by 2100. And while a few degrees might not sound like much day-to-day for one person, globally, the health impacts are projected to be huge.
Yeah.
The World Health Organization estimates around 250,000 additional deaths per year between 2030 and 2050 just due to climate change.
250,000 extra deaths a year. That's hard to comprehend. What kinds of illnesses are we talking about?
We're looking at increases in things like cardiovascular disease, heart attacks, strokes, and respiratory illnesses. These get worse with more frequent heat waves and the poorer air quality that often comes with warmer weather.
Right. Makes sense.
Then there's the rise in gastrointestinal infections, gastroenteritis, cholera, other foodborne and waterborne diseases.
How does that connect?
Floods contaminate water supplies. Heavy rains disrupt sewage systems. It creates breeding grounds for these diseases, especially after environmental disasters.
Okay. It's like a domino effect from extreme weather.
Precisely. And it doesn't stop there. Think about vector-borne diseases, things carried by mosquitoes, ticks.
Like malaria, dengue fever.
Exactly. Warmer temperatures, changing rainfall. These affect where these vectors live and how numerous they are, so diseases can spread to new areas.
And then there's nutrition itself.
Yes, climate change is projected to worsen malnutrition, especially in tropical, low-income countries that depend heavily on agriculture. Crop production gets disrupted,
Leading to food shortages.
potentially significant ones. Some projections suggest agricultural productivity could drop by 10 to 25% by 2080 in vulnerable regions.
So the very basics, food, clean water, are threatened. The source mentioned the Paris Agreement. Can you just remind us what that was about?
Sure. The Paris Agreement from 2015 was this landmark international deal. Almost 200 countries agreed to try and limit the global average temperature increase to well below 2 degrees Celsius compared to pre-industrial times.
Okay.
And they even aimed to pursue efforts to limit it to 1.5 degrees. The idea was that hitting these targets was crucial to reduce the risks.
But there have been challenges with implementing it.
Well, yes. The subsequent U.S. withdrawal in 2017, for example, created some uncertainty about hitting those ambitious goals. It highlighted the complexities of global cooperation on this scale.
It definitely paints a concerning picture of the wide-ranging health impacts. Okay, let's shift focus a bit, maybe narrow it down to the more direct effects of toxic substances, toxicology. What are the key ideas we need here?
Right, toxicology. At its core, it's the science of poisons, but it's broader than just lethal stuff. It covers how all toxic agents, chemicals, physical forces like radiation, heat, interact with living things to cause harm.
Okay.
And what's really striking, as the source points out, is just the sheer number of chemicals used commercially. Something like 100,000 in the U.S. alone.
100,000. And how many have been fully tested for health effects?
That's the thing. Only a fraction have undergone really extensive testing to understand their potential impacts.
That's a bit unsettling. So many unknowns out there. I guess that's where regulatory agencies come in, trying to manage the risk.
They do. Agencies like the EPA set permissible exposure levels for known hazards.
Yeah.
But it gets complicated fast.
How so?
Because people react differently. Our sensitivity varies hugely based on, interactions between different pollutants, our age, our genes, how vulnerable specific tissues are.
So a safe level isn't really absolute.
Exactly. It's really hard to define one single safe number that works for everyone. It goes back to that famous quote from Paracelsus.
Oh, the dose makes a poison guy.
That's the one. All substances are poisons. The right dose differentiates a poison from a remedy. Even water can be toxic if you drink way too much.
Right. Okay. And the source mentions xenobiotics. What are those?
Simply put, they're chemicals foreign to the body. Stuff from outside air, water, food, soil that we absorb.
And our bodies have ways to deal with these foreign chemicals, right? We don't just absorb them passively.
Absolutely not. We have pretty sophisticated systems to metabolize them, mostly in the liver, but other tissues too. Usually happens in two phases.
Phase 1 and phase 2.
Right. Phase I, reactions often modify the chemical, maybe hydrolysis, reduction, oxidation, usually making it more reactive, getting it ready for the next step. The key players here are the cytochrome P450 enzymes, the CYPs.
Okay, CYPs.
The crucial catalysts. But here's the twist. Sometimes phase I doesn't detoxify. It can actually activate a harmless substance into something toxic.
Oh. So the body's attempt to clean up can backfire. What happens in phase 2 then?
Phase 2 is usually about conjugation. The modified chemical, or sometimes the original xenobiotic, gets attached to another molecule, like glucuronic acid sulfate or glutathione GSH.
And that helps get rid of it.
Generally, yes. It makes it more water-soluble, easier to excrete in urine or bile. So the overall goal is neutralization and elimination. But, like we said, those phase I CYPs can sometimes spin off harmful reactive oxygen species, ROS.
ROS, those are the free radicals we hear about.
Exactly. Unstable molecules that can damage DNA, proteins, other cell parts.
Can you give an example of this activation where detoxification goes wrong?
Sure. A classic one is carbon tetrachloride, an industrial solvent. When liver CYPs metabolize it, they create this highly reactive trichloromethyl free radical.
And that damages the liver.
Directly. Causes liver toxicity. Another example, benzoaperine, found in cigarette smoke. CYPs in the lungs turn it into a metabolite that can bind to DNA.
Leading to mutations, cancer.
Potentially, yes. That's one mechanism linking smoking to lung cancer. And it's worth remembering, CYPs metabolize lots of things, alcohol, many prescription drugs, which is why drug interactions can be a problem if they compete for the same enzyme.
It really shows the complexity, doesn't it? That delicate balance. Okay, let's talk about a more visible kind of toxicity, pollution, specifically air pollution, outdoor and indoor. What are the main takeaways?
Air pollution, both outside and inside, is a huge global issue for health. It causes illness, premature death, especially for people with existing heart or lung problems.
Right.
And while maybe historically, infectious agents in the air were the bigger worry in some places, now in industrialized countries, it's more about chemical and particulate pollutants.
It feels like a modern problem, but you mentioned earlier.
It's not entirely new. Our source notes John Evelyn describing London's thick smog way back in 1661. And there was even an English law in 1306 banning coal burning punishable by death.
Wow. Seriously.
Seriously. So the awareness isn't new, but the types of pollutants and the regulations we use have definitely evolved.
Okay. So modern outdoor air pollution. What are the main culprits now?
In industrialized places, it's usually a mix of gases and particles, concentrated in cities, near industry. The U.S. EPA tracks 6 main ones: sulfur dioxide, carbon monoxide, ground-level ozone, nitrogen dioxide, lead, and particulate matter.
And these contribute to smog.
Yeah, smog is a major issue in big cities globally. Beijing, LA, Delhi, Mexico City, you name it. The lungs take the main hit, obviously, but the effects can spread to other organs too.
Ozone is confusing. Good high up, bad down here.
That's exactly right. Stratospheric ozone, way up high, is formed naturally by UV light hitting oxygen. It forms the ozone layer, which protects us by absorbing most harmful UV rays. Essential stuff.
But ground level ozone.
That's different. It forms from chemical reactions and nitrogen oxides from burning fuel, volatile organic compounds, sunlight. At ground level, is a major pollutant, irritates the lungs, makes things like asthma worse.
And the ozone layer depletion, what's the status of that? We used to hear so much about CFCs.
It was a huge concern, especially after they discovered that big depletion over Antarctica in '85 and thinning elsewhere. The main cause was chlorofluorocarbons, CFCs, used in refrigerants, aerosols.
Right.
These chemicals drift up, UV breaks them down, releasing chlorine, which destroys ozone. But the good news is the Montreal Protocol, the 1987 treaty to phase out CFCs.
It worked?
It's been remarkably successful, actually. The Antarctic hole is showing signs of recovery. It proves that international cooperation can tackle these big environmental threats.
That's genuinely good to hear. Okay, let's move indoors. Inside our homes, our workplaces, what pollutes the air there?
It's a diverse mix. Combustion products are big ones, from burning wood, coal, gas for heating or cooking, especially in lower-income countries.
What else?
Radon gas, which is naturally occurring. Environmental tobacco smoke, secondhand smoke, allergens like pet dander, dust mites, molds, even chemicals leaching from building materials or furniture like formaldehyde.
Radon often comes up in home inspections. Where does it come from? Why is it bad?
Radon is a radioactive gas. It comes from the natural decay of uranium in soil and rocks, and it can seep into buildings through foundations.
And the danger.
When you inhale it, it decays further, releasing alpha particles that damage lung cells. It significantly increases lung cancer risk, especially for smokers.
And secondhand smoke, still a major issue.
Definitely. Passive smoking exposes people to many of the same harmful chemicals as active smoking. It's linked to lung cancer, heart disease, heart attacks, respiratory problems in kids. Public smoking bans have helped reduce exposure, measured by things like cotinine levels. But exposure in homes is still a big concern.
And the biological stuff, dust mites, mold, mostly allergy triggers?
Primarily, yes. Bacteria, viruses, fungal spores, dander, dust mite, feces. These can trigger hypersensitivity reactions like asthma or allergic rhinitis in people who are susceptible. Mold needs moisture, so damp indoor environments are a problem.
Okay. Let's shift again to heavy metals. Lead, mercury, arsenic, cadmium. Our source goes into detail here. What's the overarching theme, and what are the key points for each?
The common thread for many heavy metals is their affinity for sulfhydryl groups. These are chemical groups found in lots of vital proteins. When metals bind to them, they mess up the protein's function.
Disrupting normal cell processes.
Exactly. Let's start with lead. It's easily absorbed, very toxic, affects blood, bones, nerves, gut, kidneys.
Historically, paint and gasoline were big sources, right?
Major sources. Mostly phased out now in many places, thankfully. But current exposure comes from mining, foundries, batteries, spray painting. And for kids especially, old flaking paint and contaminated soil are still huge hazards.
The Flint water crisis really brought lead contamination back into focus.
A terrible example, yes. Changing the water source caused lead to leach from old pipes, very high levels in tap water, elevated blood lead levels in thousands of residents.
And children are more vulnerable.
Much more. They absorb lead more efficiently, maybe over 50% compared to about 15% in adults. And their developing brains with a more permeable blood-brain barrier are highly susceptible to damage.
What does lead poisoning look like in kids?
Cognitive problems, behavior issues, poor school performance, ADHD-like symptoms. More severely, nerve damage causing weakness, anemia, those characteristic lead lines on the gums. You can even see lead deposits on x-rays of their bones.
And in adults?
Similar nerve damage, motor and sensory. Also hypertension, abdominal pain, lead colic anemia, kidney disease, even a specific type of gout called Saturnine gout. Subtle cognitive issues too. And the gum line can show up.
How does it actually cause this damage?
Well, that binding to sulfhydryl groups is key. It also messes with enzymes needed to make heme, the iron-containing part of hemoglobin. That causes the anemia. It can also inhibit crucial cellular pumps, leading to red blood cell breakdown. You see that basophilic stippling in red cells under the microscope.
How is it diagnosed?
Measuring lead levels in the blood is the main way. You can also look at markers of disrupted heme synthesis, like free protoporphyrin in red cells.
Okay. What about mercury, another one with a notorious history?
Indeed. Mercury also binds strongly to sulfhydryl groups, causing major damage, especially to the central nervous system and kidneys. Historically, it was used in everything from pigments to medicines.
Syphilis remedies, even.
Yes, and diuretics. It exists in different forms, metallic or elemental, inorganic salts like mercuric chloride, and organic forms, particularly methyl mercury.
And where do we encounter it now?
The main sources for most people are contaminated fish, that's methyl mercury and mercury vapor, from dental amalgams, though that's more an occupational risk for dentists. Also, gold mining in some areas releases it into rivers.
How does it get into fish?
Bacteria in water or sediment convert inorganic mercury into methyl mercury. It enters the food chain, then concentrates as it moves up biomagnification. So long-lived predatory fish like swordfish, shark, king mackerel can have high levels.
And we absorb methyl mercury easily.
Very easily from the gut, about 90%. The tragedies in Minamata, Japan, and the grain poisoning in Iraq showed the devastating neurological effects, especially for children exposed in utero.
Why is it so bad for developing brains?
Methyl mercury is lipid-soluble. It crosses the placenta easily and accumulates in the CNS. Prenatal exposure can cause severe, irreversible problems, cerebral palsy, deafness, blindness, intellectual disability.
Is there any protection in the body?
Glutathione, that GSH molecule we mentioned in detoxification, plays a big role. It binds mercury and helps remove it, offering some protection to the brain and kidneys.
But exposure is still a concern.
Yes, ongoing release from power plants, industry. Chronic low-level exposure worries people. That's why there are advisories for pregnant women about avoiding high-mercury fish.
What about other forms? Inorganic mercury, vapor.
Acute ingestion of inorganic salts hits the gut, hard ulcers, bloody diarrhea. It can cause acute kidney failure. Chronic exposure might lead to nephrotic syndrome. Inhaling mercury vapor from spills, some occupations causes that classic Mad Hatter picture. Tremors, gingivitis, bizarre behavior.
Right, the hat makers. Okay, on to arsenic, the classic poison.
Arsenic salts interfere with cellular metabolism. They hit the gut, nervous system, skin, heart. Yes, historically used as a poison.
But today, exposure is mostly unintentional.
Mostly. It's naturally in soil and water in many areas. Used in wood preservatives, herbicides. Released by mining. Can be in some herbal medicines. The big worry is contaminated groundwater. Huge problem in Bangladesh, Chile, China. Affecting millions.
Which forms are most toxic?
Trivalent compounds like arsenic trioxide.
And the effects, acute versus chronic.
Acute high-dose ingestion is often fatal. Severe GI, cardiovascular, CNS toxicity. It might interfere with energy production in mitochondria. Chronic exposure causes different problems.
Like what?
Neurologic issues can appear weeks later, neuropathy with numbness, pain. Cardiovascular effects like hypertension, heart rhythm problems. And characteristic skin changes, hyperpigmentation, hyperkeratosis, especially palms and soles.
And cancer risk.
Yes, chronic exposure increases risk of lung, bladder, and skin cancers. Arsenic-induced skin cancers often look different from sun-induced ones, may be related to problems with DNA repair.
Okay, last one in this group, cadmium. What's its story?
Cadmium is more of a modern pollutant. Toxic mainly to kidneys and lungs, possibly via ROS production.
Where does it come from?
Mining, electroplating, nickel-cadmium battery production and disposal. It gets into soil and plants from fertilizers, irrigation. Food is the main source for most people. It gets absorbed using a transporter normally meant for zinc.
And the main toxic effects?
Obstructive lung disease from damaging lung cells and kidney tubule damage that can progress to kidney failure. It's also linked to bone problems. calcium loss.
Like Itai disease.
Exactly. That was in Japan, from cadmium-contaminated rice fields. Affected postmenopausal women mainly, causing severe bone pain, fractures, kidney disease. Cadmium exposure is also linked to higher lung cancer risk in exposed workers and people near smelters. It's not thought to damage DNA directly, but likely does so indirectly through ROS.
That's quite a list of toxic metals. Our source also covers occupational health risks more broadly. What are the key points there?
Occupational health is a huge area. In the U.S., over 10 million work injuries annually, around 65,000 deaths.
And most deaths aren't from accidents.
About 90% are from toxic exposures leading to cancer, lung disease, other fatal conditions. Only about 10% are from trauma-like falls.
What kinds of exposures?
Hugely varied. Could be respiratory irritants like formaldehyde, could be known carcinogens like asbestos, arsenic, uranium, dusts or big silica, coal, grain, wood dust, fumes, vapors, gases, asbestos again, beryllium, isocyanates, vinyl chloride, radiation too, like radon in mines.
It really drives home how our workplaces shape our long-term health. Okay, let's shift to physical agents causing injury. Mechanical trauma is mentioned briefly.
Yes, mostly just noting its relevance in forensic pathology.
Right. Thermal injury, burns, hyperthermia, hypothermia. Let's start with burns. What determines how serious a burn is?
Several things. The depth superficial, just epidermis, partial thickness into the dermis, or full thickness down to subcutaneous tissue, maybe muscle. Also, the percentage of body surface area involved. And whether there are internal inhalation injuries from breathing hot air or toxic gases. And crucially, how quickly and effectively treatment is given, especially fluids and infection control.
Burns are common, right? Scalds, fires.
Very. Around 450,000 treatments a year in the U.S., mostly fire or scalding. About 3,500 deaths annually from fire and smoke, mostly at home. But survival rates in burn centers are much better now, over 95%.
What are the biggest immediate dangers with severe burns?
For large burns, say over 20% body surface area, the biggest threats are shock and sepsis.
Shock from fluid loss.
Yes, massive fluid shift out of the blood vessels due to inflammation. And sepsis because the burn site is wide open to infection. Pseudomonas is a common culprit, but resistant bugs and fungi are problems too. The body's own inflammatory response can also impair immunity.
And breathing problems.
Yes, respiratory insufficiency from inhaling heat or fumes can cause airway obstruction, lung inflammation. Long-term, you worry about scarring and persistent itching.
Okay. What about the extremes of body temperature hyperthermia and hypothermia?
Hyperthermia is sustained high body temp. Heat stroke is the worst form. The body's cooling fails. Core temp goes over 40 degrees C, 140 degrees Fahrenheit. Often stops sweating, leads to confusion, seizures, coma, high mortality.
And heat exhaustion?
Less severe. Can be due to water loss causing low blood volume and collapse, or salt loss causing cramps, weakness, vomiting. There's also malignant hyperthermia.
That's the genetic thing with anesthesia.
Exactly. Triggered by certain anesthetics, causes muscle calcium to spike, leading to rigidity, massive heat production. Very dangerous if not treated fast, linked to mutations in the RYR1 gene.
Yeah, and hypothermia.
Low body temp.
Right. Core temp below 35 degrees C, 95 degrees F. Risk factors are cold exposure, immersion, inadequate clothing, alcohol, drugs, illness.
What happens physiologically?
Initially, body tries to conserve heat, vasoconstriction, faster heart rate breathing, but eventually that fails. Heart rate slows, breathing slows, loss of consciousness, arrhythmias, potentially fatal.
Okay, electrical injury is next. Low voltage, high voltage. Yes, household current or power lines, lightning. Two main injury types, burns and disruption of nerve signals causing things like ventricular fibrillation or stopping breathing.
What determines severity?
Amperage, duration of contact, path through the body. Even household voltage can cause fibrillation, especially if skin is wet, lowering resistance. Sustained contact causes burns, entry, exit, maybe internal.
And AC versus DC current.
Alternating current, AC, can cause muscle spasms, making it hard to let go. Leads to longer contact, worse burns, even chest muscle spasms causing asphyxia. High voltage often paralyzes brainstem centers, controlling breathing, heartbeat, causes extensive burns. Lightning is the classic example.
Finally, under physical agents, ionizing radiation. You said it's a double-edged sword used in medicine, but also hazardous.
Precisely. Ionizing radiation, X-rays, gamma rays, particle radiation like alpha and beta particles, has enough energy to knock electrons off atoms, different from non-ionizing like UV or microwaves.
Where do we get exposed?
About half our exposure in the U.S. is human-made, mostly medical imaging and treatments. CT scans have significantly increased average exposure since the 80s.
So essential for medicine, but what are the risks?
Short-term effects like fibrosis, scarring, long-term, DNA mutations, cancer risk, birth defects if exposed during pregnancy. The units used to measure it can be confusing. Gray, Sievert, Becquerel, Rad, Rem. Sievert, SV, is probably best for understanding biological effect.
What factors influence the biological damage?
Several key ones. The rate of delivery giving doses spread out allows time for repair. Radiation therapy uses this, as normal cells often repair faster than cancer cells. The total dose, higher dose, worse effect. The type of radiation alpha particles do more dense local damage than X-rays.
Okay.
Also, oxygen levels. Oxygen makes cells more sensitive because it helps form free radicals. That's why some hypoxic tumors are radiation resistant. And cell proliferation, rapidly dividing cells like bone marrow or gut lining, are more vulnerable.
What about blood vessels?
Vascular damage is important too. Damage to the endothelial cells lining blood vessels can cause narrowing or blockage over time, leading to poor healing, fibrosis, chronic tissue damage from lack of blood flow months or years later.
And the core damages to DNA.
Primarily, yes. Single and double-strand breaks, base damage. If it's not repaired properly, it can lead to cell death, mutations, cancer, or birth defects.
Our source mentions threshold doses for specific effects.
Right. Things like temporary sterility in tests at just 0.15 SV, bone marrow depression at 0.5 SV, permanent sterility around 2.56 SV depending on sex, hair loss 3 to 5 SV, cataracts 5 SV. These are estimated thresholds for acute effects.
What does radiation damage look like at the cellular level?
Surviving cells can show chromosome damage, deletions, translocations, problems with cell division, abnormal chromosome numbers, nuclear changes, apoptosis. You might see giant cells with weird nuclei persisting. Yeah. High doses just cause rapid cell death.
And total body irradiation.
That's particularly devastating. Different syndromes depending on dose. Hematopoietic syndrome, 110 Shay, hits blood cell production. Gastrointestinal syndrome, 10G, destroys the gut lining. Central nervous system syndrome, 50G, is rapidly fatal.
The blood system is especially sensitive.
Highly sensitive. High doses cause rapid drops in lymphocytes, shrinkage of lymph node spleen. Bone marrow precursors die off, leading to aplasia. You see predictable drops in blood counts, neutrophils down within days, lowest point around 2 weeks. Recovery takes months if the dose wasn't lethal.
What about long-term late effects?
Fibrosis in organs like lungs, kidneys is a big one, often linked to that vascular damage, and cancer risk is definitely increased.
We know this from
atomic bomb survivors increased leukemia, thyroid, breast, lung cancers, Chernobyl survivors, thyroid cancer, Marshall Islands fallout, thyroid, leukemia, birth defects, also second cancers after radiotherapy. Yes, AML, myelodysplastic syndrome, other solid tumors. The risk at lower doses, like from medical imaging, is harder to pin down precisely, but evidence suggests increased risk above maybe 50 millisieverts acute dose, possibly even lower. Kids are at highest risk. The underlying mechanism is that initial DNA damage persisting in surviving cells can eventually trigger cancer years later.
A sobering look at radiation effects. Okay, let's move to our final major topic, nutritional diseases. This covers both not enough and too much, right?
Exactly. Malnutrition, in the broad sense, inadequate intake or absorption leading to loss of body mass, weakness. Still a huge issue in low-income countries. But then obesity is a massive public health problem globally.
So dietary insufficiency. What does a basic adequate diet provide?
Energy, from carbs, fats, proteins, essential building blocks, amino acids, fatty acids, and vitamins and minerals for coenzymes, hormones, structure. Primary malnutrition is when the diet itself lacks these. Secondary is when another condition messes up intake or absorption.
The source talks about severe acute malnutrition, or SAM. What is that?
SAM is life-threatening. WHO defines it by very low weight for height, like 3 standard deviations below normal. Affects maybe 50 million kids globally, huge prevalence in poor countries, major cause of child mortality, worsened by conflict, famine.
How is it diagnosed beyond just looking?
Weight for height is key, but also assessing fat stores, skin fold thickness, muscle mass, arm circumference, sometimes serum proteins like albumin. And there's growing interest in the gut microbiome's role. The bacteria in the gut seem to play a part.
There are different types, right? Marasmus and kwashiorkor.
Yes, those are the 2 main forms. Marasmus is severe deficiency of both calories and protein. Leads to extreme wasting, loss of muscle, and fat. Serum albumin is often relatively normal, though. Anemia, immune deficiency are common. The head looks too big for the body.
And kwashiorkor.
That's when protein deprivation is worse than the overall calorie reduction. The key feature is severe loss of visceral protein, leading to low albumin levels, hypoalbuminemia.
And that causes
Edema, swelling,
Mm.
which can actually mask the muscle wasting. They also get fatty liver, skin lesions like flaky paint, hair changes, apathy, poor appetite, immune problems. Weight might be 60–80% of normal, but the edema hides the true extent of wasting. Immune system damage tends to be worse than in marasmus.
And cachexia, is that related?
It's a form of secondary malnutrition, seen in chronic diseases like cancer, AIDS, profound muscle loss, often resistant to just feeding more. It's covered in more detail elsewhere.
It seems like malnutrition and infection go hand in hand.
A truly vicious cycle. Infection raises nutritional needs, impairs absorption. Malnutrition weakens immunity, making you prone to infection, which worsens malnutrition, a major driver of mortality, especially in kids.
Does severe malnutrition affect brain development?
Critically, if it happens in the first year or two of life, or even prenatally if the mother is malnourished, it can cause lasting damage, potential brain atrophy, fewer neurons, impaired myelination. Big impact on cognitive development.
What about other systems? Bone marrow.
Often becomes hypoplastic-reduced red cell production. Leads to anemia, often from multiple causes: iron, folate, protein deficiency, effects of infection. Other things you see are thymus lymphoid atrophy, bad for immunity, issues from parasites, specific vitamin or mineral deficiencies like iodine.
How is SAM treated?
Carefully. Refeeding has to be gradual to avoid refeeding syndrome, which is dangerous. Slowly increase calories, protein, monitor closely. Milk-based therapeutic foods help the gut recover.
The source also covers eating disorders, anorexia, and bulimia.
Yes, anorexia is self-induced starvation, severe weight loss. Leads to hormonal changes like amenorrhea, low thyroid, heart issues, low bone density. A specific finding is this gelatinous transformation of bone marrow fat.
And bulimia.
That's binge eating followed by purging, vomiting, laxatives, excessive exercise. Weight might be near normal, but it causes serious problems like electrolyte imbalances, heart arrhythmias, esophageal tears.
Okay, let's focus on vitamins now. So many of them. Fat-soluble versus water-soluble.
Right. 13 essential ones. A, D, E, K are fat-soluble, stored more readily, but need fat for absorption. B vitamins and C are water-soluble, generally not stored long-term, need regular intake. We make some, like D from sun, K from gut bacteria, but diet is key for all. Deficiencies can be primary, dietary lack, or secondary absorption metabolism issues.
Vitamin A usually linked to vision.
Night blindness is often the first sign, yes. It's part of rhodopsin, the visual pigment. But A does much more. Maintains specialized epithelial skin, respiratory tract. Deficiency leads to changes there, called squamous metaplasia, increasing infection risk. It's also crucial for immune function, cell growth, differentiation. Its active forms, retinoids, regulate genes. Also an antioxidant.
How do we get it? How is it used?
From diet is preformed vitamin A, animal sources, or carotenoids like beta-carotene plants, converted to retinol, transported by RBP, stored in the liver. Active forms are retinal vision and retinoic acid gene regulation.
So deficiency causes night blindness and
Xerophthalmia, dry eyes, pteau spots, corneal ulcers, eventually keratomalacia, and blindness. Also those epithelial changes, more infections like measles mortality, immune deficiency.
Can you have too much vitamin A?
Yes. Acute toxicity causes headache, dizziness, vomiting, stupor. Chronic toxicity, weight loss, anorexia, bone joint pain. Fracture risk increases. And synthetic retinoids used for acne are potent teratogens, cause birth defects.
Okay. Vitamin D, bone health, but maybe more.
Its main job is maintaining calcium and phosphorus levels for bone mineralization, nerve muscle function. Prevents rickets in kids, osteomalacia in adults.
But we mostly make it ourselves, right? From sun.
Primarily, yes. UVB light converts a cholesterol precursor in skin to vitamin D3. It accounts for maybe 90% for many people. Dietary sources include fatty fish, fortified foods. D2 comes from plants.
But it needs activation.
Right. 2 steps. First in the liver to 25-hydroxyvitamin D. That's what's usually measured in blood tests. Then in the kidney to 1025-dihydroxyvitamin D, the active form.
And that activation is regulated
tightly. Low calcium via PTH and low phosphate stimulate the kidney step. High active vitamin D inhibits its feedback control.
How does active vitamin D work?
Binds to the vitamin D receptor, VDR, in cell nuclei, regulating genes. Increases calcium absorption in the gut, calcium reabsorption in the kidney, Works with PTH to release calcium phosphate from bone by stimulating osteoclasts. Keeps plasma levels high enough for mineralization.
Deficiency causes rickets and osteomalacia. How common is that?
Still a problem worldwide with poor diets, low sun exposure, also caused by kidney disease, malabsorption. Milder deficiency is common, especially in older adults, linked to bone loss, fractures.
Well, what do rickets osteomalacia actually look like in the bones?
Excess unmineralized matrix, osteoid. In rickets, the growth plates are messed up. Cartilage overgrows, doesn't calcify properly, leading to skeletal deformities. Bowed legs, rachitic rosary on ribs, skull changes. In osteomalacia, adult bone remodeling is affected. New bone doesn't mineralize properly, making bones weak, prone to fracture.
Any roles beyond bone? Immune system.
VDR is found in many tissues. Macrophages can make active vitamin D locally. It seems to have immunomodulatory effects, but clinical trials haven't shown clear benefits for things like respiratory infections from supplementation. Still being researched.
And toxicity. Too much sun.
No, sun exposure is self-regulating, but megadoses of supplements can cause hypervitaminosis D, high blood calcium, metastatic calcifications, bone pain.
Vitamin C, ascorbic acid, scurvy.
Deficiency causes scurvy, yes. Humans can't make it, need it from diet fruits, vegetables mainly. Most diets have enough.
What's its main job?
Crucial for collagen synthesis, needed to hydroxylate proline and lysine, which gives collagen strength. Also a major antioxidant, involved in neurotransmitter synthesis, immune modulation. Its role in sepsis is being studied.
What does scurvy look like?
Weakness, bleeding gums, hemorrhages under the skin, petechiae, ecchymosis, and around bones. It's really painful in kids. Poor wound healing, anemia. You can see it in older people with poor diets, alcoholics, dialysis patients.
Okay, lots of other vitamins and minerals too, covered in tables in the source. Let's switch to the other extreme. Obesity. Huge global problem.
Massive. Linked to type 2 diabetes, dyslipidemia, cardiovascular disease, hypertension, cancer, and central obesity fat around the organs seems riskier than subcutaneous fat.
How prevalent is it?
Epidemic levels in the U.S. and many high-income countries, rising fast elsewhere. WHO estimated 650 million obese adults globally in 2015. Driven by complex factors, genetics, environment, psychology, but fundamentally it's an energy imbalance. Intake exceeds expenditure.
And the hypothalamus controls this balance.
It's the master regulator, yeah. Gets signals from the body about energy stores, then activates circuits to either increase intake, decrease spending, anabolic, or decrease intake, increase spending, catabolic.
What are some of those signals?
Hormones mainly. Leptin from fat cells signals fullness, ghrelin from the stomach signals hunger, PYY and GLP-1 from the gut signals satiety after eating. Insulin also plays a role.
And the hypothalamus integrates these.
Right. In the arcuate nucleus, specific neurons respond. PUMC-CART neurons are anorexigenic, reduce appetite. NPY-AGRP neurons are orexigenic, increase appetite. They balance each other and respond to peripheral signals.
So leptin should reduce appetite. Why doesn't leptin therapy work well for obesity?
Because many obese individuals develop leptin resistance. The signal is there, but the brain doesn't respond properly.
What about gut hormones like GLP-1?
They signal satiety, and GLP-1 receptor agonists are used therapeutically now for obesity. And diabetes, they reduce intake, help insulin secretion.
Adipose tissue isn't just storage, right? It makes hormones.
Exactly. Leptin, adiponectin levels are actually lower in obesity, which might be bad because it normally helps improve insulin sensitivity. There's also brown fat, BAT, which burns energy for heat. Research is looking at how to activate that.
So what are the main health consequences when this complex system leads to obesity?
Increased mortality overall. Big risk factor for type 2 diabetes. Insulin resistance is key. Cardiovascular disease, hypertension, obesity contributes through multiple pathways.
Like inflammation.
Yes, obesity, especially central, is linked to chronic low-grade inflammation. This inflammation likely contributes to insulin resistance, hypertension, maybe even blood clots and cancer.
Oh, also.
Dyslipidemia, high triglycerides. Low HDL, bad for arteries.
Other issues?
Non-alcoholic fatty liver disease, NAFLD, is very common, can progress to cirrhosis. Gallstones are much more frequent. Obstructive sleep apnea, increased risk of certain cancers.
Right, the cancer link. How does obesity increase cancer risk? Several mechanisms proposed.
Yes, likely multiple factors. The insulin-IGF axis, high insulin, can increase free IGF-1, which promotes cell growth. Changes in steroid hormones, more estrogen production in fat tissue, increased availability. Lower adiponectin levels might reduce its normal anti-cancer effects. And that chronic inflammation we mentioned probably plays a role too.
Which cancers are linked?
Esophagus, thyroid, colon, kidney in men. Esophagus, endometrium, gallbladder, kidney in women. The individual risk increase might be modest, but because obesity is so common, it accounts for a large fraction of total cancers.
Beyond just obesity, does diet composition itself affect cancer risk?
It's complex. Some dietary components might be harmful, like aflatoxin in moldy grains, liver cancer, or nitrosamines formed from nitrates in cured meats, gastric cancer link. High fat intake might promote colon cancer via bile acids.
And protective factors.
Lack of protective factors like fiber, vitamins, antioxidants, and fruits vegetables might increase risk, but proving specific dietary components prevent cancer is hard. Antioxidant supplements haven't shown clear benefits in large trials. Low vitamin D might be linked to some cancers, but more research needed.
So no magic diet for cancer prevention.
Not proven. The clearest link is that maintaining a healthy weight through a balanced diet reduces risk, because obesity itself is a major risk factor.
And diet impacts other diseases too, beyond malnutrition and obesity.
Absolutely.
Yeah.
Sodium restriction for hypertension, fiber for diverticulosis prevention. Caloric restriction increases lifespan in animals, though its relevance for humans is debated. Omega-3 supplements for heart disease showed little benefit in recent large reviews. And the gut microbiome is emerging as a huge player in obesity and metabolic health generally.
It's just incredible, isn't it? The sheer number of ways our environment, what we eat, how much we eat, how profoundly it all shapes our health, right down to the cellular level. Climate change, toxins, nutrients.
Yeah, it really is. And I hope walking through this, connecting the dots between historical pollution, the subtle ways metals poison us, the far-reaching impacts of vitamin deficiencies, the intricate hormonal control of weight, I hope it provides some of those aha moments.
Definitely. It's a lot to take in, but the goal was that deeper, more expert-level understanding, really mastering these connections.
Exactly. Seeing health not just as an internal state, but this constant, dynamic interaction with our world.
So, thinking about that intricate dance between our bodies and our surroundings, here's something for you to consider. What single change in your personal environment or diet do you think could have the most significant positive impact on your long-term health? And what more might you need to know to make that call? Something to ponder.
A great question to leave things on.
Join us next time for another in-depth exploration on the deep dive.